and welcome to Preemie Chats, a space where we connect, learn, and share stories about the world of prematurity. I'm Fabiana Bacchini. I'm a proud preemie parent and executive director of the Canadian Premature Babies Foundation, or CPBF, and I'm honored to have you join us today. Preemie Chats is brought to you by CPBF, a parent-led charitable organization dedicated to supporting families, advocating for the needs of premature babies, and providing the latest information and resources to help parents and caregivers navigate this journey. Whether you're a parent, a healthcare professional, a researcher, or someone interested in understanding more about preterm birth, you are in the right place. Together, we are building a supportive community where stories are shared, questions are answered, and new evidence is explored, and no one feels alone. But be sure to visit our website, thecanadianpreemies.org, where you'll find helpful resources, our latest project, and most importantly, a community of people who wants to see our little babies thrive. And if you're watching this live today, join the conversation, share your questions and comments in the chat box, and we'll try to address them during our program. If you're watching a recorded session, you can still connect with us through our website. It is through meaningful conversations like this that we can advance practice and grow together. Let us know where you're watching from. We'd love to hear from you. And on today's episode, we'll be discussing RSV with Dr. Paolo Manzoni, diving into an important topic for families of preemies. This session will describe what RSV is and what it implies for families and society in general. We will highlight which are the current tools to protect babies and prevent the widespread burden, the negative outcomes of this disease on the babies and families. We all know that RSV is very dangerous for our premature babies because they are much higher risk of severe infection. And I have the honor to have here joining us live from Torino, Italy, Dr. Paolo Manzoni, who is a neonatologist and pediatrician. He's the head of the Italian Society of Neonatal Infectious Diseases and founding board member of the Excellence Research Network on RSV, named Resvinet, since 2014. Dr. Manzoni's primary research interests include pediatric and neonatal infectious diseases, fungal infections, human milk bioactive nutrients, RSV-related diseases, COVID-19 neonates and infants, and retinopathy of prematurity and neonatal nutrition. He authored some 220 research articles published in peer-reviewed international leading journals. Dr. Manzoni, thank you so much for joining us here today on our very first Preemie Chat of 2025.
Thank you, Fabiana, for inviting me. Thank you, all of you, for tuning in and listening to this talk. And needless to say, it's an honor for me to kick off the new year with this topic. I feel confident because it's something that I've been tackling as a neonatologist, as an intensive care physician in neonatal intensive care unit, and lately also as a pediatrician and a respirologist committed with this network of excellence called the Resvinet, where we gather together several specialists in the pediatric world, covering the different specialties of medicine and pediatrics that can be merging with the need to find an hypothesized solution for RSV. Absolutely. So it's my pleasure now to go through this presentation and
and for everyone, just a reminder for everyone watching us live today, please do send your questions, your comments, and we'll try to address them during the Q&A after Dr. Manzoni's presentation. So the floor is yours.
Thank you again, Fabiana. So my main disclosure is that I am a part of this network of excellence, and I invite you to visit the website and to stay up to date with the research and educational materials that we are providing in the area of RSV. We are, as I was telling you, a bunch of passionate physicians dealing with the pediatrics and the neonatologists. And what's linking us together is the patient for RSV and finding out which can be the solution for this very dangerous pathogen. The outline of the presentation is built in a way that the main objective of this talk, that is bringing RSV to the attention of the family and individuals, can be covered by tackling what is bronchiolitis, what is the main agent of bronchiolitis, hence RSV, which are the treatment clues, but most of all, which are the prevention clues in order to go to action and to have some very poignant closing remarks and take-home messages for everyone. The first slide I'm showing you is this one that links together the extremes of a lifetime. Infancy and elderly ages are both affected by respiratory viruses such as RSV, because they, even though they are apparently very far in time and age, they are unfortunately having similar characteristics of immune suppression or immune decreased ability to mount defenses and exposure to other environmental and transmittable disorders that can be pushing forward their infection. But we are focusing on infants, and the clinical progression of respiratory syncytial virus, just like every respiratory virus, is starting from inhaling droplets and getting the virus particle in contact with the upper respiratory tract anatomical entities, and hence to go being swallowed and being transmitted down to the lungs and to the lower respiratory tract. The typical timeline of infection is a few days to develop a rhinitis-like disease in the upper respiratory tract, and few more days to switch in severity and in location, going down from the upper to the lower respiratory tract with all the symptoms and signs that relate to bronchitis or bronchiolitis. The infection from the nasopharynx to lower respiratory tract can be spreading both through viruses that are swallowed, but also through epithelial cells that are affected by RSV, and that by detaching can be going down to the respiratory tract in lung and bronchioli, and hence infect other structures of the respiratory tract. And the main disturb and the main damage that RSV produces is eliciting mucus production, is provoking detachment of epithelial cells, just like I was saying, and with these two main mechanisms, getting to having bronchioli and airways obstructed by some plugs of mucus and sloughing cells that ultimately prevent alveoli to expand and to exchange air and gas. So the last step of infection is alveoli that, after having been trapped with air remaining there, do collapse and actually have no more ability to perform their function, that is, exchanging gas between air and bloodstream. The narrow lumen of bronchioli is critical, because even more in the neonate, because the neonate has a very narrowed lumen of bronchioli, even in healthy conditions. And you may imagine how narrower this lumen becomes with obstruction caused by debris, by staph cells, by fibrin, or by edema. And in this anatomy pathology slide, you can see very nicely that at the right, the lumen of the bronchioli is fully obstructed by these spotted blue cells that are actually neutrophils, spanning around in a variable composition of other cells that have been detaching from the epithelium of the bronchioli. But do not forget that RSV is not limiting to respiratory tract. RSV infection may extend beyond lungs by affecting liver, brain, heart, and also by producing pneumonia as a negative outcome, or ab ingestis features related to difficulty of swallowing and incoordination of cough and swallowing. The agent of bronchiolitis is RSV, or at the very least is the most frequent one. And RSV is an enveloped RNA virus with two main types, A and B, and a typical ability to attach to the epithelial cells and to fuse with them hints, and you see it very nicely in these slides, disseminating its ribonucleic material in the cell and using the machinery of the cell, just like every virus, to replicate and ultimately to produce new copies of viruses that are getting budded outside of the cell and can go and getting disseminated towards other cells or the lumen of the airways. Notably, cells after having been infected by RSV very frequently come to an end, can be getting to damage and termination, and getting them destroyed can attach all together, forming what's called syncytia. Syncytia, something that is included in the name of this virus, means a glue, a kind of mud of several dead cells that lose their walls, that mix together all their structures, and that ultimately plug the airways or the spaces where they are detached. But I'm going straight to the point of transmission and hence prevention, because the first main information everyone needs to have is the survival time of RSV. And unfortunately, the bad news is that RSV can survive on surfaces for hours. As you see in this slide, there can be short times of survival if you are using clothes and gloves and gowns. But if you happen to touch your nose like this, and then to touch a countertop, or this one, a mobile phone, viruses, just like RSV, can remain hours and hours and can be transmitted to other people very easily. And this is why the contagious ability of RSV is very high, is much higher than influenza. It's a little lower than COVID-19, but it's actually higher than all other respiratory viruses that we are familiar with. And therefore, this means that a baby infected by RSV is a source of infection for many other babies, even though their contacts are not that close. Please keep in mind that in our countries, in Canada, in Italy, in the northern or in the southern hemisphere with temperate climates, the outbreaks of RSV are typically seasonal. The timing may vary partially from country to country, but in the northern hemisphere like ours, the RSV season spans over from November till March or early April, whereas it's exactly the contrary in the southern hemisphere, just like Argentina or South Africa or Australia. So we can say that RSV is circulating in the world all year long, and with the travels and flights, it's very easier that seasons can be partially modified. And this is also why RSV is by far the most frequent cause of respiratory infections in children, as I was saying you, with millions and millions of cases every year, with millions of cases of hospitalization, and with some thousands and thousands of babies who actually can die by RSV. And this is occurring mainly in low income countries, but it's not that impossible also in medium or high income countries like ours. So RSV is a global problem because the infection rates of RSV is extremely high. We can say that mostly all infants below 2 years of age get infected. The pyramid of severity is such that only a minority of them get hospitalized, or even a lower minority of them gets into the need to be assisted in an intensive care unit. But if you consider that every year million and million of cases occur, you can understand by these proportions that it's absolutely an important problem of public health everywhere. And it's even more important in the first weeks of life, because especially when you happen to be born as a premature infant, the first weeks of life, the first 2 months of life are very critical. And it's no surprise then that the peak of hospitalization is around 2 months of age, just because this baby is not yet fully protected and not yet fully competent. I was telling you about mortality, and mortality, unfortunately, is relevant in low-income countries, whereas in high or mid-income countries, mortality is affecting mainly babies who get RSV after having a very important comorbidity or a very important health condition. So our babies with extreme prematurity, with neurological disorders, with critical heart disease, with chronic lung disease, have a very high risk to get a very severe infection by RSV. The first weeks of life are critical, as I was telling you. And what's critical there, it's the bunch of antibodies transferred by the mother to the baby, enabling the neonate to have some defenses, even though he is not yet competent in mounting an immune defense. So antibodies to the fetus can be given through the placenta during the pregnancy, can be boosted with a maternal vaccine, and we'll touch this point later on, and can be also transferred through fresh breast milk. So the first basic tool to have more defenses against RSV is obviously to have a transfer during the pregnancy of antibodies and to continue this transfer through breastfeeding. Unfortunately, preterm infants not only have an immature immune system, but also have less time to get a full transfer of antibodies during pregnancy, because as you see here, the bulk of transmission of IgG occurs after 32, 33 weeks of gestational age. That means that extreme premature infants, as an example, those being born below 28 or 29, have a very poor levels of antibodies being transferred by the mothers. And you see here that even only few weeks earlier delivery implies having, as an example, less than 70 or 80% less antibodies compared with having been born at term. So the point is to understand how to correct this weakness. And this comes even more important because we know very clearly that the levels of maternal RSV antibodies are lowering and decreasing over weeks of life. And this once more adds to the premature inability to have a good clearance from respiratory tract of viruses and pathogens, a decreased capacity for gas exchange, and an inability once more to mount an immune protection, not only because they have an immature system, but also because they do receive less IgG. So the whole of these reasons gives us a clear understanding of the increased risk for premature babies to get RSV and to get RSV in a very severe form. This is very pictorial, but it's very explanatory. You see here what's happening with an airway being mature here in the left, being premature here in the middle, and being premature with mucus plugging and increased airway constriction like it happens with RSV infection. So you see here how wide is the space for air gas exchange, how narrow is the space here. So we are clearly facing a very critical baseline condition of inability of these preterm infants to clear infections, to exchange gases, because their anatomy is not yet able and competent to develop these functions. Having said that, let's move forward and let's go to what can we do as physicians and as caregivers, and for those of you who are parents as a family, to treat and manage RSV. Well, the first, let's say, unfortunate news is that most of the guidelines and scientific recommendations actually focus on tests or treatments to avoid and not on tests or treatments to promote. And this is because, unfortunately, there is no specific treatment for RSV. We have consistent criteria for diagnosis now, and you see here an example that we are using as researchers in all our studies in order to get consistency in the definition of bronchiolitis. We have criteria and indications to have a baby hospitalized, or in turn to have a baby being able to remain home or in the community. The main criteria is a saturation of oxygen being persistently lower than 90 or 92%. But as a pediatricians and neonatologists, we do not only take a look to the saturation, obviously, but we also look very carefully to the age of the infant, to the presence of apnea, to dehydration. Let's keep in mind that the neonates and young toddlers need to be breastfed or to get a bottle every 2-3 hours. And when a baby is coughing every 2 minutes, it's very difficult to him to get ability to be fed nicely and correctly. So dehydration is always behind the corner, and it may be occurring very quickly. In different countries, there are different thresholds of saturation, but the main message is that when a baby is saturating less than 90%, it's this baby needs hospitalization, absolutely. A message for you families and for all caregivers. Let's remember that this tool may be lying simply because we are not cleaning the nares, we are not cleaning the nose of the baby, and therefore the baby is not able to feature a correct saturation. By only suctioning the nasal airways, as you see here, before and after suctioning, saturation index increases by far, and this translates into a very wide proportion of hospitalization that can actually be avoided. So the message for the family is when your baby is coughing and having a runny nose, please be courageous, stand up and suction the nares and the nose of your baby, because he or she will soon get better in breathing. Besides that, the only reasonable posture and attitude with this very uncertain presence of recommendations and treatments is to put together all the societies being competent and being devoted and committed with pediatrics and neonatology, and to coordinate common and shared guidelines. In Italy, we did this. We did that. We put together. You see the logos of 20 and more societies implicated in pediatric and neonatal healthcare, and all of them were able to agree on a shared document and to promote a shared culture of management of bronchiolitis. Summing up, let's go to the strategies for treatment and prevention. I was telling you that as for treatment, we are very weak. So we will focus mainly on a preventative and prophylaxis strategy. But a few words about treatment. There are antivirals in development, but once more, the main message is that no treatment is effective. Everything has been tested, everything has been tried. If you happen to have your baby hospitalized, you'll see that the physicians and colleagues can administer bronchodilators, adrenaline, steroids, antibiotics, whatever, but all the scientific societies in all the world, as you see here, and including yours in Canada, do not recommend this treatment, simply because they are not evidence-based. So there's an anarchy. Physicians are often under pressure by parents and by the hospital to give medications, and often forced to prescribe the useless therapies because of many reasons, because of the fears of the parents, because of the fears of the doctors themselves, because of the need to try something in order to get this baby healthier in a quicker time. But unfortunately, if you want to be evidence-based, there's almost nothing. So the only cornerstone for treatment is hydration, and when necessary, oxygen supplementation. Nothing more and nothing less. As for antivirals against RSV, something that could take that could happen just like for flu, where we do have a oseltamivir. As you see here, there are several compounds under development, but the bad news is that only one of them, zelicapavir, is moving consistently forward towards the pipeline of development and investigation, and it's predicted as of today to be available in a few years, not immediately, but probably in 5-6 years it'll become available. But what can we do now? So we cannot rely on antivirals. else. We cannot rely on anything, so we have nothing actually to treat the baby. So the only effective strategy is by far prevention. And as for prevention, let's focus again on the previous slide. We can have not specific measures and specific measures. As for not specific measures, hygiene is a cornerstone, and we had a clear demonstration of hygiene ability to prevent infection during the COVID pandemic. With the lockdown, with the gowns, with gloves, with hand washing, with hydroalcoholic gels, RSV nearly disappeared. Obviously, this cannot be something that we implement on a daily routine basis. We need to live, we need not to be confined. But the main message is that we need to be very careful in washing our hands, in knowing the modalities of transmission, in knowing the duration of viability of a virus like RSV in the environment, and therefore educate ourselves as caregivers, parents, and families to minimize transmission through bad hygiene. Breastfeeding. What's better than breastfeeding for preventing infection? In Italy, we had a very nice study recruiting 2,000 diets, mothers, and neonates, and we cohorted them for 1 year, reporting the incidence rates of bronchiolitis. And as you see in the green line, babies being breastfed had a 57% reduction in bronchiolitis over the first year of life. So breastfeeding is effective. Vitamin D also is very effective because vitamin B attenuates RSV-induced inflammation without affecting viral clearance. And we know that infants with severe RSV infection have a lower plasma concentration of vitamin D. So vitamin D is absolutely critical and needs to be given. Also, because we know that since birth, vitamin D deficiency is associated with bronchiolitis. This is a very nice study from the Netherlands showing that in the cord blood, levels lower than 50 nanomole per liter of vitamin D were associated with bronchiolitis. So mothers also during pregnancy need to get vitamin D given. But the cornerstone for all treatments, but that's better to say for all preventative strategies, is the prefusion F protein in the RSV variant. And this prefusion protein, the prefusion F protein, pre-F, has a number of antigenic sites in its conformation, and all of them can be targeted by monoclonals. Monoclonals antibodies have a long history, now a 25 history of effectiveness and safety in infancy. The first one who was developed is palivizumab, is still present, but palivizumab was unfortunately limited for use only to extreme premature babies or critical heart disease babies. Palivizumab, needless to say, showed a very high degree of efficacy, a full reassurance as for safety, and it has been the cornerstone of prevention for 25 years, being also effective on something that is related to RSV infection, and that's called post-viral wheezing. If you probably you may know if you happen to have a baby, but babies having a bronchiolitis in the first weeks of life do often repeat wheezing and respiratory distress feature for several times over the first 1 or 2 years of life, every time they get a runny nose. And this ability of RSV to replicate wheezing can be somewhat stopped by administering palivizumab. So by preventing an early infection, we can prevent also a late negative outcome of this infection. But unfortunately, I was telling you, palivizumab is only confined to a very limited number of infants. Now we have, luckily, new strategies, nirsevimab and clesrovimab, new generation monoclonal antibodies, and maternal vaccination against RSV during pregnancy. Let's get back again to the pre-F protein. As you see here, the antigenic sites that are targeted by these different maps are differently located in the RSV pre-F protein, but the common point among all of them is that these sites are well exposed and can be nicely targeted by palivizumab, site2, clesrovimab, and nirsevimab. And therefore, it's no surprise that nirsevimab, when was first studied, and I had the pleasure to be one of the performers of this study, showed a 80% reduction in hospitalization and a 70% reduction in episodes of bronchiolitis by RSV leading to a medical visit. And therefore, in the last couple of years, nirsevimab has been ultimately implemented in several countries. In Europe, the first one was Spain, and then France, Luxembourg, and Italy this year added on. We performed a meta-analysis, a systematic review a few months ago in June, having a incredibly high proportion of efficacy for these implementation strategies, 88% reduction of hospitalization due to bronchiolitis thanks to nirsevimab administered to all neonates. Clesrovimab is a second one, is almost on the doorways to be introduced and being available. And also clesrovimab, compared with palivizumab, showed in this very important and very ambitious trial in 27 different countries the same figures of efficacy as for palivizumab, also for clesrovimab. So we'll be having, and I'll be skipping that, two different monoclonal antibodies to prevent RSV, and these monoclonal antibodies can be administered only once in a year because their half-life is longer than palivizumab, and can be administered soon after birth before discharge from the nursery in order to get the baby fully protected for the first months of life. But also, and I'm going to the end, we have a tool that is very important. The maternal immunization during pregnancy enhances passage of antibodies through the placenta, but also may impact on the cocooning strategy and on the passage of antibodies through breast milk. And you see here all the diseases that can be prevented by vaccination in pregnancy. We had a few years ago the COVID-19 experience, and now we have also RSV adding to this list. And RSV being a targeted goal has been shown by this very ambitious international trial a couple of years ago with more than 50,000 mother and infants enrolled to see whether administration of an RSV vaccine between 24 and 36 weeks of gestational age was able to prevent RSV bronchiolitis in the offsprings. And the results were stunning because a 70% efficacy in prevention of severe RSV episodes was seen in the first 6 months of life after vaccination. So currently, RSV vaccination during pregnancy is an additional strategy to prevent early bronchiolitis by RSV. So we are going now to the end and to the conclusion of this talk. I hope you enjoyed and you could, and I hope you could capture the main messages. I will summarize them here once more. RSV is a very important agent of infectious disease and it's affecting everyone. Infants less than 1 year of age are at very high risk of developing a severe form of RSV disease with several complications and localization. Mortality is not negligible in industrialized country, and it's considerable in low middle income countries. RSV infection early in life is associated with a series of negative respiratory outcomes that can span over a lifetime. No available specific treatment is there other than supportive treatment, hydration and oxygenation. And therefore, prevention is critical. Preventative strategies not only rely on hygiene and vitamin D, but also on specific tools like monoclonal antibodies to be administered to the neonate soon after birth, maternal vaccination during pregnancy, and promoting breastfeeding that enhances passage of natural antibodies from the mother to the baby. Well, I thank you very much for your attention. I invite you to visit our website, theresvinet.org, and I'll be happy to get the criticisms of Fabiana, but most of all, the questions of you all. Thank you.
I'm mute. I should know this by now after 4 years doing this Premier Chats. But so thank you so much for joining us here today, for sharing your expertise, the latest research, what is coming up. It's, I think, very exciting times for our families. So thank you for sharing all this. But I will bring a comment from one of our participants, from Holly. Thanks so much, Dr. Manzoni, for such an informative session on RSV. My 25-weeker had RSV when she was 1 and was re-hospitalized at that time. Thank you for your work advancing the care of our little warriors. Holly, thank you so much for coming back to the Premier Chats. We missed you. Holly was our avid audience for a long time here at Premier Chats. So we all know the impact of RSV in our preemie babies, especially the impact on parents, on when baby get readmitted in hospital after have a long NICU stay. So I think what is happening in this scenario with RSV now is very exciting for our families. There's a lot of new evidence coming out, new strategies. But I want to go back to the very basics for new parents and parents who are just leaving maybe the hospital babies after a NICU stay, or babies were sick. It's a very critical time, the winter time, for these families, especially here in the North Hemisphere. It's RSV and flu season, and parents are always very concerned. And you talk about very simple strategies on wash your hands and limited the number of people coming to the house. But what you say to a family, somebody's sick in the house, a mom is sick, or a parent is sick, or the sibling goes to daycare and comes home sick, what should they do? Because we get this question a lot from our families.
What should I do? It's I would be a wizard if I should be able to tell the magic bullet to be used. Everything that can, let's keep in mind that everything, every behavior, every approach, every strategy that can minimize the number of viruses passing from one individual to another one is welcome. So we need always to have this in mind. If we do not wash our hands, if we kiss our baby every second minute, if we smoke in the household, if we do not open the windows to change the air, if we touch our nose and then take the mobile and give the mobile to the baby to play with that, we are disseminating viruses. So it's there is no single and simple tool, but it's a comprehensive portfolio of strategies and behaviors that can be altogether helpful. In neonatology, we call this a bundle. a bundle is a group of behaviors and tools that one by one are not able to reach a goal, but all together, when performed all together, can achieve a goal. So the bundle in a family with several, one or two young kids in the house, the bundle during winter time should be to minimize the transmission of viruses from one member to the other member. And therefore, all those items that I was mentioning are altogether providing a significant benefit, and step by step, brick by brick, we can build up a wall.
Right. You did mention on your presentation about the saturation when the baby should be admitted in hospital. And I remember also from my personal experience bringing my baby home, I did have the monitor at home because my baby was on home oxygen. But for the families who bring the baby home without a monitor, how do they know when the baby needs to seek immediate medical assistance? Because we know, like, not all parents are aware of the baby changing colors or having a super hard time breathing, when to call the doctor, when to go to the doctor, when to go to emergency, because it's a more serious situation.
Well, respiratory distress usually is understandable and can be captured by most of us, even though not everyone is a physician or a nurse. And one thing that I can recommend as a neonatologist and a pediatrician to parents, and I am doing it always in my office, is undress your baby and watch his or her chest while he's breathing. You can't have an idea without undressing the baby. And if you undress the baby and you happen to see retractions and to see a difficult work of breathing, this is something that it's visually impacting and usually can be captured. And if you happen to see it once, you never forget it. And also noises, unusual noises in the breathing work can be alerting, can be a sign of alert. And usually the parents, mothers and fathers, can capture and can recognize when the baby is starting breathing with an unusual noise. So I think these two things are actually prompting parents to bring the baby and have a visit.
Absolutely. And I always share a personal story that my son got very sick a month and a half after being discharged from the hospital. And one thing that I learned while he was in the ICU is to always look at the color of his lips, if he's changing the color and how heavy he was breathing. And we did have an episode when I actually had to do CPR on my own son because he turned blue and his chest he had so much difficulty breathing. And yes, is it something that you always remember and you don't forget that labored breathing? And when I had to do CPR on him, and I'm grateful that I had the skills to do it because I learned at the hospital. But I always, think about the families who don't have all the resources or the skills to do such a thing. I mean, I know here in Canada, we have 911 services, so ambulance comes immediately to your house. And you always tell families, like, when in doubt, call 911, because it's better to, be very proactive in breathing situations because it can go down really quickly. But there's a lot in your talk that I really want to touch on. One is the breastfeeding, because we know how important it is and the evidence is there to protect. So if the mom is sick, can she still breastfeed her baby we have this question a lot from parents, right? Should you stop breastfeeding or should you continue to breastfeed even during that time?
No, we generally recommend to not to stop breastfeeding unless the mother is such critically sick that she can't bear, she can do it. Once upon a time, it was common to discourage breastfeeding when the mother had very high fever peaks, like 40 Celsius or something like this. The rationale behind this is that it's complex, but just to make it short, is that if you have a bacterial infection and you have an extremely high peak of temperature, these might be associated with the dissemination of these pathogens in the bloodstream and also in the milk. But I would be very, very simple in my recommendations to all mothers. If you think you can do it, continue breastfeeding. There's no reason to stop breastfeeding if you have a cold, if you have a fever, because keep always in mind that at the same time you are transmitting, you are giving the baby not only the potential pathogen but also the antibodies towards against this pathogen that you are developing, that you are producing. So really, and actually there is no reason to stop. Once more, I repeat it, unless the mother is such critically sick that she can do it. We want alive and kicking mothers, so there's no need to die for having a breastfeeding continued if the mother is not doing well. But there is no medical reason to stop it.
And it's fascinating what the body can do and how we can help our babies in so many ways. And so that brings us to the maternal vaccine piece of this conversation, because you talk about the maternal vaccine is an optional. It is available in Canada, was approved by Health Canada for late in the pregnancy. And you mentioned your studies, there was a lot of women enrolled or pregnant people enrolled between 24 to 36 weeks gestation. Is there any side effects moms or pregnant people should be concerned about? It has showed the safety of this vaccine combined with all the other vaccines that are available now for pregnant people.
Yes. No, actually, there is a very solid base of data showing safety, both in the mothers and in the infants. The reason why in Canada the window of gestational age during pregnancy may be different compared with other countries is that every single country licensed this vaccine with the different time windows, because every single country received and perceived safety signals in a different way. So we are in an historical moment where the national pharmacological entities are not yet fully aligned, and therefore we have countries where, like Austria, where the vaccine is recommended after 24 weeks of gestational age, and others like USA on the opposite extreme, where administration can be given only after 32. And all the other countries, including Canada and Italy, are in between. But I think that this will change very quickly. And my personal view as an expert is that the best possible time window for administration of maternal vaccine is between 28 and 33, 34, just because the bulk, the core of antibodies can be transferred during those weeks. And also consider that if you are pregnant and if you wait and wait and wait to get the vaccine administered, you might be delivering earlier than a vaccine. So if you happen to be in a country where administration is only beyond 32 and you are delivering at 31, obviously you weren't able to receive the vaccine. So these are points that need to be harmonized among the countries, but my very convinced and very transparent message is that the vaccine against RSV is efficacious, is safe. The data about the study, about safety, are fully reassuring, and also the data that are going to get published in these weeks about the post-marketing implementation of the vaccine are again once more reassuring and excluding any very specific question mark about that.
Thank you for clarifying that, because I know, like, very early studies, there was some preterm birth related to the vaccine or understanding of that situation. So it's good to know that new evidence is coming strong. But my question to you is just to clarify for people who are watching us live today, because most of the antibodies is passed on to the mom, to the baby on the last trimester of the pregnancy. Even if the parent received this vaccination at 28 weeks and delivers at 31, how much of the antibodies is passed on to the baby at that point, or the baby should still receive prophylaxis after birth?
Oh, Fabiana, this is a very timely question, and you hit the target as usual, because this is exactly something that we are debating among ourselves, among the community, and with the stakeholders. So we still don't know honestly whether such a baby deserves getting nirsevimab or palivizumab or not. So we have not yet data studying whether it's enough to have coverage by maternal vaccination even though you are born preterm. We don't know whether addition of nirsevimab may arithmetically add and confer twice as much or the triple of protection, or whether adding nirsevimab to some maternal antibodies translate into not increasing the overall viable load of antibodies. So as of today, we are still in an area where we are applying common good sense. And common good sense, I was advising just yesterday a good friend of mine, a neonatologist from Spain, because he had the same issue, and he was posing me the same question. I'm having two babies, two twin babies being born at 32, and the mother was administered the vaccine at 29. What am I doing now with nirsevimab? And I was honestly telling me, dear friend, I don't know, because we don't have the data yet. But I can only suppose, based on common good sense, that nirsevimab is something that probably is not detrimental. You are certainly not providing unsafe effects by giving nirsevimab, and I don't see how nirsevimab could be given an issue to a baby having a portion of a maternal antibodies, because this would be the same as, or more or less similar, to a natural infection contracted by the mother during the pregnancy. So should the mother have RSV infection during pregnancy, she should transfer naturally formed antibodies, and we wouldn't know that the mother has been having RSV infection simply because probably this mother was displaying a mild runny nose or something like this. So actually, this problem is already overcome, in my opinion. I would recommend to give nirsevimab in all babies being born prematurely, even though the mother has been administered a vaccine.
Right. It is, I think, is a good question that will be continue to come into the surface as all new vaccines or prophylaxis come into place. Here in Canada, we're still using palivizumab in most of provinces. We switched to nirsevimab in Ontario and Quebec for this season, and looking forward to see what's happening for this coming season 2025, 2026, because there was some conversation with parents. So is it safe? Is a new product? Is it safe for our baby? So there's so much conversation on hesitancy, efficacy, safety of the medication. I think you have to continue to work with families, educate families, and educate healthcare providers on how to educate our families on the severity of RSV for our babies. As you mentioned, for the mom, is a runny nose, is a little cold. For our babies, it looks very, very different. So that's why we always talk about RSV. You bring the latest evidence, what is happening in this scenario, not only in Canada, but around the world. Like you can see, there's so many inequities and variations of which product to use, how to use, when to use. Yeah. And now you mentioned clesrovimab. We always have to learn how to pronounce it. So can you tell us a little bit what that is? It is similar to nirsevimab. It's one dose. It's for all babies. We know very well palivizumab for 5 injections throughout the whole season. 25-year drug in the market, very safe, very efficacy is there. So now we have one new one coming to the market. The next one almost ready to be approved.
Correct. It's another new generation monoclonal antibody. It's a very similar, let's say, to nirsevimab, but because the technology used to prolong the half-life is practically the same. Clesrovimab claims to have an even more active potency against both the strains of RSV, the A and B, covering both of them even more potently than nirsevimab, but this is a claim, so we'll see whether this is confirmed. And also there are some hints that it could be even a little longer lasting than nirsevimab, so probably one administration covering 6 months instead of 5. But basically they are very similar, and so the main advantage of this new monoclonal, in my opinion, will be that there will be 2 in the market and prices will unavoidably decrease. And this is a very good news because palivizumab, that was extremely effective, was hampered by the high cost for diffusion and availability and affordability for several infants and several countries who could have benefited from it. So in my view is that provided that both of them are more or less equally effective or with modest differences, the great advantage for all healthcare providers and ultimately for all patients and families will be to have more strategies, more than one, to prevent RSV. And this is always a benefit. It is also always beneficial in a market.
So just for parents who are here, who are new to this understanding of how this prophylaxis work, and it's not a vaccine that has a long-term effect like other vaccines that the babies have on the schedules. And we know palivizumab was 5 injections throughout the winter, more or less, through the high-risk months. And nirsevimab is 1 injection that covers the 5 months, and this new one probably a little bit longer. So what happened on the second season? Because now in Canada, we were approved for the first season. Are those babies at as much risk as their first winter, going to the second winter of their lives? How long those parents should be really concerned about RSV and not having these strategies into place on the second and third year for those preemie babies' lives? But
So
I
now
think in particular with the babies, the extreme preterm babies who have BPD, because I think this is a big concern for the families. I mean, we also know the risk of late preterm babies, but particularly the extreme babies, the extreme preterm babies.
Oh yes, you touched a very nice point. There is, and I like it. I like to underline once more that we are talking about things that are not vaccines. So these are antibodies. Giving antibodies to a baby is somewhat like refilling a car with fuel. So we had a car. It's a very nice one. Unfortunately, can't drive because there is no fuel, and we are giving fuel. Palivizumab was available as a fuel only for very limited models of cars in the market. Now we have nirsevimab and possibly clesrovimab being available for whichever type of car. But the point is that this is a fuel, and the fuel is consumed as the car is driving, can cover 100, 200, 500 miles, then the fuel is over and the car stops. Luckily, Mother Nature enables our cars, our preemies and our neonates to develop the ability to self-produce fuel while they are running their miles. So after a few months or after a few miles, this car will be able to be independent from refilling. And this is a natural model. You are correctly placing the question whether a second season can be disclosing surprises or novelties in the likelihood of these babies to get infected and to get severely infected. We still don't know yet because we still don't have wide data set to study what's happening in the following seasons. Keep in mind that nirsevimab was started as a seasonal coverage only last year in Spain, Luxembourg, and France, and limitedly to some areas also in USA. So we are still lacking time to study what's happening to the formerly neonates once they become young infants and toddlers in the second year. But what we know very well is that RSV can affect a baby also when this baby is 2 years or 3 years old. But the point and the good news is that the severity of this infection is decreasing as age increases.
Right.
So it's possible that more babies will get infected by RSV in the second year simply because they weren't meeting RSV in the first one. But this does not imply that this is a danger.
Right. Okay, thank you. Before you wrap up, I could continue this conversation for a long time because there's so much to unpack on RSV and what is up, what's coming, and what's happening now. But before we go, I would like you to tell us a little bit about the Resvinet. What are you doing there? What are you trying to accomplish? And who is involved?
Well, I'm happy to talk a little bit about that. Resvinet is a network of experts, I would say a network of crazy passionate once about RSV, and it was formed in 11 years ago in the Netherlands. We gathered, we were already friends and colleagues sharing this interest. Each one of us had already performed the studies, investigations, and published a lot of things. And we decided to gather together in order to have a networking experience and in order to unite our forces to achieve our goals faster and more effectively. And this was actually the case because we published a lot of papers. We were and we are increasingly involved in designing studies, in promoting educational activities. As an example, this is one of the educational activities that Resvinet to some extent is involved with, and I'm happy that you invited me for that. Our goal is to share and disseminate the information about RSV and to help the families to understand scientifically what's better, what can be done better for their babies, and which studies and which drugs can be reliable, which are more, which are less, and which are the streamlines of progress towards a better health in this area as years go by. So we are fully committed to that. We are performing a lot of activities, educational congresses, conferences, road shows, webinars, papers, advising, so all of that. And I'll be happy to remain in touch with your organization as well, because we are proud enough to tell you that we can help somewhat. We are very happy to be in a position to give some help in this area.
Thank you. This is such a great work, especially in this time that we are living with so much misinformation, disinformation, and to have this resource for families with scientific evidence-based, the latest evidence is so very important. And what I really like about Resvinet, I participate in a few webinars, is very lay language that we parents can actually understand and learn from experts and help us to make better decisions for our babies. So Dr. Manzoni, thank you so much for joining us here today. Such a great talk to open 2025. You were part of our 300 and something sessions that we've done over the last 4 years since the beginning of the pandemic. And I'm so grateful that you brought this incredible knowledge that you have, your insight to expertise into our Premi Chats for this year. So thank you. And I hope I will see you again here.
Thank you. Thank you, Fabiana. Thank you to the Canadian Premature Babies Foundation. Thanks to all those who were listening and watching this lecture today. And I would say likewise. I really wish I could be back here again shortly. And so consider me enrolled for future chances and future opportunities to collaborate with you. My pleasure.
Dr. Manzoni. Thank you so much. And to all of you who joined us today, thank you so much for being part of our first Premi Chat of 2025. And if you missed part of today's session or you want to revisit pieces of it, you can find this episode and all past episodes on our YouTube channel and our website, which is here, thecanadianpremies.org. While you were there, explore the many resources and support options we offer to help families on their journey. We have a lot of information on respiratory illnesses, and you have RSV materials in 19 languages. And as a charitable organization, CPBF relies on the generous support of people like you. Your donations allow us to continue empowering families of premature babies every step of the way. Together, we can create a brighter future for all preemies and their families. So thank you again for being part of this community. We'll see you again next Friday, 1 p.m. Eastern Time, for another live episode of the Preemie Chats. Stay well.